Hi, I'm Dr. Chris Lewis, one of the chief educators here at Doctors in Training, and I want to welcome you to the Solid Anatomy lecture on the orbit. In this video, we'll be covering muscles of the orbit, including the extraocular muscles. Also in the lecture, we'll discuss motor and sensory information of the orbit, and blood supply to the orbit. As a side note, the lecture pairs well with the lecture on the eye, another head and neck lecture in the Solid Anatomy series. I'll be back later for some clinical correlations and the end of session quiz, but for now I'm going to turn it over to our primary lecturer, Dr. John Phelan.
The orbits are the pyramidal cavities in the skull that protect the eyeballs. 7 bones contribute to the orbit: the frontal bone, the ethmoid bone, the lacrimal bone, the maxilla, the zygomatic bone, the sphenoid bone, and the palatine bone. Like all pyramids, the orbits have 4 walls, a base, and an apex. The base is just the orbital opening, which is surrounded by the orbital margin, or rim, and the apex is the optic canal in the lesser wing of the sphenoid bone. The medial walls are parallel to each other, while the lateral walls diverge and are at a nearly 90-degree angle to each other. The axes of the orbits are therefore at about 45 degrees to each other, but the eyeballs are oriented within the orbits such that the axes of vision are parallel. You may recall the bony structure of the orbit from the Solid Anatomy lecture on the skull. The majority of the superior wall, or roof, of the orbit is formed by the frontal bone, which separates the orbit from the anterior cranial fossa above. The frontal bone also forms the superior margin of the orbit. A supraorbital notch, or supraorbital foramen, is located just lateral to the medial end of the superior margin. The supraorbital neurovascular bundle supplying the anterior part of the scalp passes through this notch, or foramen. Anterolaterally, there is a shallow fossa in the frontal bone for the lacrimal gland. The lesser wing of the sphenoid bone contributes to the posterior part of the roof of the orbit. The hole in the lesser wing of the sphenoid at the apex of the orbit is the optic canal, through which passes the optic nerve and the ophthalmic artery. The frontal bone, the greater wing of the sphenoid bone, and the zygomatic bone each contribute to the lateral wall of the orbit. The frontal process of the zygomatic bone forms most of the lateral part of the orbital margin. Posteriorly, the superior orbital fissure is a gap between the greater wing of the sphenoid on the lateral wall and the lesser wing of the sphenoid on the medial wall. The superior orbital fissure transmits the ophthalmic division of the trigeminal nerve, the oculomotor nerve, the trochlear nerve, the abducent nerve, and the superior ophthalmic vein. Most of the inferior wall, or floor, of the orbit is formed by the maxillary bone. Minor contributions to the floor come from the palatine bone medially and the zygomatic bone laterally. Posteriorly, a gap between the maxillary bone on the inferior wall and the greater wing of the sphenoid on the lateral wall is the inferior orbital fissure. The inferior orbital fissure and the superior orbital fissure are continuous with each other, forming a boomerang shape whose apex points medially. The maxillary division of the trigeminal nerve and the inferior ophthalmic vein pass through the inferior orbital fissure. The lacrimal bone and parts of the ethmoid, frontal, and sphenoid bones form the medial wall of the orbit. On the inferior part of the medial wall, at the anterior edge of the lacrimal bone, is the opening for the nasolacrimal canal. The nasolacrimal duct travels down this canal and opens lateral to the inferior nasal concha in the nasal cavity. Posterior to the lacrimal bone is the delicate orbital plate of the ethmoid bone, which is sometimes called the lamina papyracea in observance of its paper-thin appearance. At its junction with the roof of the orbit are 2 tiny foramina that transmit the anterior and posterior ethmoidal nerves and vessels. The periosteum of the bones of the orbit is called the periorbita. It is continuous with the periosteal layer of the dura mater through the optic canal and the superior orbital fissure, and with the periosteum of the rest of the skull across the orbital margin and through the inferior orbital fissure. The eyeball only occupies about 40% of the volume of the orbit. The remainder is filled by fat. Physically separating the eyeball from the orbital fat is the bulbar fascia, or Tenon's capsule. The bulbar fascia is a fibroelastic membrane that forms the socket for the eyeball to rotate within. It is fused around the sclerocorneal junction along with the conjunctiva and covers the eyeball to the optic nerve posteriorly. The thin space between the sclera and the capsule is the episcleral space, which is filled with loose areolar tissue that allows the eyeball to roll around inside the capsule without friction. While the sclera is covered by the bulbar fascia, the cornea is covered by the bulbar conjunctiva, which, like the bulbar fascia, fuses along the sclerocorneal junction. The conjunctiva is a clear mucous membrane that lines the inner surface of the eyelids as the palpebral conjunctiva and reflects onto the cornea as the bulbar conjunctiva at the conjunctival fornices. The space between the palpebral and bulbar conjunctiva is the conjunctival sac. When the eyelids are together, that is, when the eye is closed, the conjunctival sac is closed. Goblet cells within the membrane secrete mucus that allows the inner eyelids to move across the cornea, as occurs when blinking the eyes, for instance, without friction. The mucus, together with the tears from the lacrimal gland and accessory lacrimal glands, and lipid secretions from the tarsal glands in the eyelids, protects the corneal epithelium and keeps it free from irritants such as dust. The core of the eyelids is a dense connective tissue plate called the tarsus. It is connected to the orbital margin via the membranous orbital septum, which becomes continuous with the periosteum. The orbital septum keeps the orbital fat from spilling past the orbital margin. The tarsal plate is also connected to the medial and lateral margins of the orbit by medial and lateral palpebral ligaments. Fibers of the orbicularis oculi muscle extend between the skin and eyelids and the tarsus and attach to the medial palpebral ligament. You may recall from the solid anatomy lecture on the face and scalp that this muscle is responsible for closing the eye. The eyelashes grow in a double or triple row of follicles at the free margins of the eyelid near a series of ciliary glands that secrete sebum. Infection of these glands results in what is commonly referred to as a stye. The lacrimal glands are almond-sized serous glands resting in a fossa of the frontal bone at the junction of the lateral and superior walls of the orbit. They consist of columnar epithelial acinar cells surrounded by myoepithelial cells. The acinar cells secrete lacrimal fluid, or tears, which flow through the tear ducts that open into the lateral corner of the superior conjunctival fornix. Tears flow inferomedially within the conjunctival sac and collect in the lacrimal lake. Tears are taken up by capillary action through lacrimal puncta into lacrimal canaliculi that end in the lacrimal sac. The lacrimal sac drains inferiorly into the nasolacrimal duct, which runs through the nasolacrimal canal of the skull and opens into the inferior meatus lateral to the inferior nasal concha in the nasal cavity. This pathway explains why our noses run when we produce a lot of tears.
Okay, let's go through the clinical correlation. Dr. Phelan discussed styes in the lecture, but I want to discuss styes and some other eyelid pathology in a little more detail here. So let's go through these questions. So first is, what is a chalazion? So a chalazion is a non-infectious inflamed tarsal gland. So these glands are also called meibomian glands. And this forms a kind of rubbery nodule. It irritates the eyeball. Now these irritate, but they're not generally that painful. So if you squeeze them, they're not that painful, but they are going to cause some irritation to the eyeball itself. Next we have hordeolum. So a hordeolum is also the other way of saying sty, and we probably say sty because hordeolum is kind of a weird word. So this is an infection of the eyelid, and this is usually caused by Staph aureus. And this can be from either an internal sty or an external sty. And unlike the chalazion that we just talked about, these are painful. Now, an internal sty occurs because of the infection that's occurring in that meibomian gland. And then the external sty, which is a lot more common, which you see a lot of times in the office, is from obstruction of certain things. So an obstruction of an eyelash follicle, that's probably the most common thing that we see. The glands of Zeiss are another one. These are sebaceous glands on the eyelid margin. And then there's these other glands called the glands of Moll, which are ciliary glands, and these are apocrine glands on the eyelid margin as well. All right, so let's get back to that lecture.
Parasympathetic fibers to the lacrimal gland originate in the pons in the lacrimal nucleus, which is associated with the superior salivatory nucleus. These preganglionic parasympathetic fibers run in the facial nerve and leave with its greater petrosal branch, just anterior to the geniculate ganglion. The greater petrosal nerve joins the deep petrosal nerve, which carries sympathetic fibers, to form the nerve of the pterygoid canal, which, as you might imagine, runs through the pterygoid canal at the base of the pterygoid process. The pterygoid canal opens into the pterygopalatine fossa, where the pterygopalatine ganglion resides. The parasympathetic fibers synapse here, and the postganglionic fibers join the zygomatic branch of the maxillary division of the trigeminal nerve, which enters the orbit through the inferior orbital fissure. The sympathetic fibers from the deep petrosal nerve pass through the ganglion without synapsing. They already synapsed at the superior cervical ganglion, and also join the zygomatic nerve to follow it into the orbit. The postganglionic, parasympathetic, and sympathetic fibers pass through a communicating branch of the zygomatic nerve to join the lacrimal nerve, a branch of the ophthalmic division of the trigeminal nerve, which they follow to the lacrimal gland. The parasympathetic fibers are secretomotor, meaning they cause tear production or lacrimation, while the sympathetics appear to be involved in vasoconstriction of arteries supplying the gland. The extraocular muscles, which are used to voluntarily move the eyeball to direct the pupil toward visual targets, are the superior, inferior, middle, and lateral rectus, and the superior and inferior oblique. They pierce the bulbar fascia and insert on the sclera. Their fascia is continuous with the bulbar fascia and with the paraorbita. The rectus muscles take their origin off of a common cone-shaped tendon, the annulus of Zinn, or the annular tendon. It is continuous with the periorbita and the dural sheath of the optic nerve posteriorly, and forms a cone surrounding the anterior sides of the optic canal and part of the superior orbital fissure. Blood vessels and nerves entering the orbit through these openings pass through the annular tendon. The four recti muscles pass anteriorly along the respective sides of the bulbar fascia, pierce it, and insert on the sclera a few millimeters posterior to the sclerocorneal junction. The superior oblique muscle originates from the junction of the medial wall and roof of the orbit and passes anteriorly towards the superomedial corner of the orbital margin, where its pulley, or trochlea, is attached. The trochlea is a cartilaginous structure that blends in with the periorbita. The superior oblique becomes tendinous, passes through the pulley, and turns backward, proceeding laterally until it pierces the bulbar fascia at about the center of the eyeball. It passes between the superior rectus muscle and the eyeball and inserts on the sclera posterior to the midline, or equator, of the eyeball. The inferior oblique muscle originates from the floor of the orbit just lateral to the opening of the nasolacrimal canal. It passes backward and laterally, pierces the bulbar fascia and runs between the lateral rectus and the eyeball before inserting on the sclera deep to the tendon of the lateral rectus. The actions that the extraocular muscles can perform on the eyeball are named in reference to the change in position of the pupil as the eyeball is rotated within the bulbar fascia. Pointing the pupil superiorly is elevation. Pointing it inferiorly is depression. Pointing the pupil towards the median plane or looking at the nose is adduction of the pupil. Pointing the pupil away from the midline is abduction. The pupil may also spin around its axis. Spinning towards the midline is intorsion. Spinning away from the midline is extorsion. Intorsion and extorsion of the pupil allows the visual field to remain steady when the head is tilted. If you stare at a fixed object while tilting your head towards your right shoulder, your right pupil will intort and your left pupil will extort to keep your retinas level with the object you are staring at. The medial and lateral rectus muscles adduct and abduct the pupil, respectively. The superior and inferior rectus muscles also perform some abduction, while the superior and inferior oblique muscles, since they are originating on the medial extent of the orbit, perform some adduction. When the pupil is abducted, the superior and inferior rectus muscles are aligned with the axis of the eyeball and are able to elevate and depress the pupil maximally, respectively. As the pupil is adducted, the ability of the superior and inferior rectus muscles to elevate and depress the pupil lessens. When the pupil is fully adducted, they are ineffective at elevating or depressing the pupil. The superior and inferior oblique muscles act in the opposite manner to the superior and inferior rectus muscles. When the pupil is adducted, the superior oblique muscle maximally depresses it, while the inferior oblique maximally elevates it. The ability of the oblique muscles to act on the pupil lessens as the pupil is abducted. The inferior oblique is the best extorter and the superior oblique is the best intorter. But the inferior rectus also extorts, while the superior rectus also intorts. The other voluntary muscle of the orbit is the levator palpebrae superioris. It originates on the lesser wing of the sphenoid, superior and anterior to the optic canal. It runs anteriorly, just superior to the superior rectus muscle. Its insertion tendon fans out to insert on the skin of the upper eyelid and the superior tarsal plate. When the muscle contracts, it elevates the upper eyelid. There is also a smooth intrinsic muscle in the superior eyelid, the superior tarsal muscle, that raises the eyelid during a sympathetic response. Denervation of the superior tarsal muscle or the levator palpebrae superioris muscle results in ptosis, or drooping of the eyelid. The oculomotor nerve provides motor innervation to the levator palpebrae superioris muscle and to all of the extraocular muscles except for the superior oblique and the lateral rectus, which are innervated by the trochlear nerve and the abducens nerve, respectively. Each of these three cranial nerves arises from separate nuclei bearing their names in the brainstem. The oculomotor nerve is carrying motor nerves from the oculomotor nucleus in the midbrain and preganglionic parasympathetic nerve fibers from the Edinger-Westphal nucleus. The oculomotor nerve runs through the lateral wall of the cavernous sinus, the dural sinus just lateral to the fossa for the hypophyseal gland in the skull. The nerve enters the orbit through the superior orbital fissure and divides into a superior and inferior division. The superior division provides motor innervation to the superior rectus and to the levator palpebrae superioris muscles. The inferior division carries the parasympathetics to the ciliary ganglion, as described earlier, and the motor nerves to the medial rectus, the inferior rectus, and the inferior oblique muscles. The trochlear nerve arises from the trochlear nucleus in the midbrain and also runs in the lateral wall of the cavernous sinus before entering the orbit through the superior orbital fissure. It then quickly ends in the proximal end of the superior oblique muscle. The abducens nerve, or abducent nerve, originates in the abducens nucleus in the pons and runs not in the wall of the cavernous sinus, but actually through the sinus, surrounded by venous blood. It enters the orbit through the superior orbital fissure and plugs into the medial surface of the lateral rectus muscle. It may help you to recall the innervation of the lateral rectus if you remember its primary action is abduction. Abduction, abducens. With the motor nerves to the orbit covered, let's talk about sensory nerves. We've already discussed the most obvious sensory nerve of the orbit, the optic nerve, or cranial nerve number 2. The remaining sensory nerves that pass through the orbit are branches of the first and second, or ophthalmic and maxillary, divisions of the trigeminal nerve, cranial nerve number 5. As we've mentioned before in previous solid anatomy lectures, these nerves are sometimes abbreviated V1 and V2 for Roman numeral 5, first or second division. The cell bodies of the neurons making up the ophthalmic and maxillary divisions of the trigeminal nerve are located in the trigeminal ganglion that hides under the dura mater just lateral to the apex of the petrous portion of the temporal bone on the floor of the middle cranial fossa. Their central processes project back to the trigeminal sensory nuclei in the pons and the medulla. The peripheral processes of the ophthalmic nerve pass through the lateral wall of the cavernous sinus, then enter the orbit through the superior orbital fissure. The 3 main branches of the ophthalmic nerve in the orbit are the nasociliary nerve medially, the frontal nerve in the midline of the orbit, and the lacrimal nerve laterally. The lacrimal nerve carries sensory innervation from the lateral half of the eyeball and skin over the upper eyelid. The frontal nerve, which runs along the superior surface of the levator palpebrae superioris, is made up of the supraorbital nerve centrally and the supratrochlear nerve medially. The supraorbital nerve, which passes through the supraorbital notch or foramen, on or in the orbital rim, and the supratrochlear nerve carries sensory innervation from skin over the upper eyelid and the forehead. The nasociliary nerve gives off several branches. The anterior and posterior ethmoidal branches run medially and enter the tiny foramina we mentioned in our discussion of the bony orbit to provide sensation to the nasal cavity and to the mucosa of the ethmoidal sinuses. The long ciliary nerve provides sensory innervation to the medial half of the eyeball. The infratrochlear nerve carries sensory innervation from more skin outside the orbit. You're probably aware of the tear reflex. Someone pokes you in the eye and your lacrimal gland produces tears. The nerve in the sensory pathway of this reflex is the ophthalmic division of the trigeminal nerve. Cut that nerve and it stops reflexive lacrimation, but not emotional lacrimation. The maxillary division of the trigeminal nerve also runs in the dura mater, making up the lateral wall of the cavernous sinus. But instead of passing through the superior orbital fissure, it drops through the foramen rotundum to enter the pterygopalatine fossa. Several branches are given off in the fossa that head elsewhere, but the remaining portion of the nerve enters the orbit through the inferior orbital fissure. We already mentioned that the zygomatic nerve gives a communicating branch that allows autonomic nerve fibers to reach the lacrimal gland. The remaining branches of the zygomatic nerve innervate skin over the cheek. The infraorbital nerve runs through the infraorbital groove and canal on the floor of the orbit and opens on the face through the infraorbital foramen. It does not innervate anything in the orbit, just skin on the lower eyelid, upper lip, and lateral nose. The ophthalmic artery supplies blood to the eyeball and orbit. the blood supply to the eyeball is covered by the central artery of the retina and the posterior ciliary arteries. The remaining branches of the ophthalmic artery follow the branches of the ophthalmic nerve and are named identically. The superior and inferior ophthalmic veins, which pass through the superior orbital fissure, drain the orbit directly into the cavernous sinus. The central vein of the retina may drain into one of the ophthalmic veins or drain directly into the cavernous sinus.
So that covers the orbit. Now I want you to pause the video and answer the end of session quiz questions. There will be some questions covered that were not discussed in the lecture, but just do your best and then we'll go through the answers together. Let's get going. First question. What is the name of the inner membranous lining of the eyelid? Easy one, remember that's the conjunctiva. Next, which artery pierces the optic nerve? That's going to be the central artery of the retina. Next, from what ganglion do the lacrimal glands receive stimulation? That's going to be the pterygopalatine ganglion. Next, if you cut the lacrimal nerve back at the apex of the orbit, will you retain lacrimal gland function? So the answer to this is yes. The lacrimal secretomotor nerves actually don't run with the lacrimal nerve from below until almost at the gland itself. Next, what is the action of and the nerve supply to the levator palpebrae? So this is going to be raises the eyelid, and this is going to be ocular motor nerve, and that's going to be cranial nerve 3. Next, which artery supplies the lacrimal gland? And that's going to be easy, the lacrimal artery. Next, what are the check ligaments of the eye that check AB and adduction, so abduction and adduction of the globe? So that's going to be your medial and lateral palpebral ligaments. Next, to what does the term palpebra refer? That's going to be referring to the eyelid. Next, which three bones comprise the outer orbit, each contributing 1/3? That's going to be your frontal, maxillary, and zygomatic. Next, which way will the eye deviate if the abducens nerve, so cranial nerve 6, is lost? It's going to go medially. Next, what is the most superior muscle of the eye? That's going to be your levator palpebra superioris. Next question. What portion of the levator palpebrae muscle is controlled by the superior cervical ganglion? So this is sympathetic nervous system and is responsible for ptosis and Horner syndrome. That's going to be the superior tarsal muscle. All right, so we're almost done. Now we actually provided some images for you to label. Recalling these images in a time setting will help you to perform well on the practical part of your exam. So label the images and then we'll be finished. Thanks.